Hi, I want to welcome you to this session where we're going to talk a bit about communication and dementia. I'm Zena, Aldridge, I'm Dementia Nurse Consultant with Norfolk and Waveney Integrated Care Board, as we're now known. Dementia can bring with it a multitude of problems with communication, and it's going to be unique to the person themselves depending on the type of dementia that they have, but equally how the dementia affects them. So it could be that they struggle with finding words or remembering words. It could be that they've lost the social cues and clues around conversational interactions, so they might speak over someone, or they might not know how to interject in a conversation as confidently as they might once did. Their use of language might be different, and they might say things that are a little bit inappropriate, and people are offended by it. But often it's about people just losing their ability to connect the words in a way that is meaningful within the conversation. So people can withdraw from conversation because they're frightened of saying the wrong thing in the wrong situation. As you can imagine, we've all made social faux pas in the past, and then when you do make those social faux pas, perhaps you say the wrong thing or you think you've said the wrong thing, you might withdraw from that situation and not do it again because of fear of upsetting someone or making a fool of yourself. So imagine if you're someone with dementia and you know, you go into a shop, for example, and you say the wrong thing or you're unable to find the right money. Those kind of things can make you feel really vulnerable, and so you withdraw from those situations. So it's really important to understand how it might be impacting on that individual, because I think I've said to you before, once you've met one person with dementia, you've met one person with dementia. So don't assume that someone's communication is affected in any particular way. It's really about getting to know them and how it means for them. It might well be that their attention is impaired, so it might mean that they get distracted within conversations. It might mean that their memory is quite short term. So trying to avoid those really long sentences, lots of options for responses might be a way of minimising that difficulty for people with dementia. So short questioning and perhaps minimal answers might enable them to be part of the conversation, so they're not distracted by sort of a really lengthy sentence with lots of options at the end. As well as dementia, it's really important to remember that someone might have sensory impairment. So if you think about it, the majority of people who develop dementia are older. And as we get older, it is more likely that we're going to have either hearing or visual impairment. So if you sort of think about it yourself, if you've already got difficulty finding words, if you can't hear someone or see someone, it's going to be even more difficult to understand and make yourself heard. So if we look at the figures here, there's 1.4 million, over 1.4 million people aged 65 to 84 who actually have difficulties with their vision, and a further 580,000 people over the age of 85 who have some form of visual impairment. More than 70% of people aged over 70 have some hearing impairment, and that might just be from very low level, but to people who are almost deaf. And there are people who also have both hearing and visual impairment. So if you look at the figures there, over 220,000 people aged over 70 have both hearing and sight impairment. And if they also develop dementia, you can understand that's going to present some really significant challenges for them. And I'm going to come back to that in a case study later in the session. One of the things that's really important to remember as well is when we talk about communication, we're not just talking about verbal communication, the ability to talk. Most people with dementia will be able to communicate in some form right up until the end of their life. They're often seen as uncommunicative because they may not be able to speak verbally, but actually they can communicate their needs and preferences in other ways. So if you look at it here, actually only 7% of what we say and communicate is verbal. The majority of what we say and do is actually from our non-verbal communications, from our posture, our gestures, and then thinking about our tone as well. That can be really quite something that is really communicates a lot of different things. You can say the same word 3 or 4 times, but you say it in a different tone and it means different things. For example, if you're asking someone if they'd like to take their medication, if you say, "Joe, are you going to take your medication now?" That's very different to, "Joe, would you like to take your medication now?" You start to think about not only how you present yourself, but actually how you present the words, because that can mean the difference between someone engaging and get their care they need to have their needs met, or actually refusing care because they might feel frightened and vulnerable by the tone of your voice. So it's really important to remember. As you'll probably have guessed from some of these sessions, I quite enjoy talking. I'm known for it. I'm not a quiet person. So not being able to have a voice and being able to engage with people and have communication is really difficult for me. Yes, I like to withdraw and spend some time on my own, but actually I gain something from that social interaction. And that's no different to anyone else. We all have our level of engagement that makes us feel safe and comfortable and secure with who we are. So it's important to recognise that actually if you start to lose your confidence in your skills with communication, people might withdraw. So we need to find ways of drawing them out and engaging them, because otherwise it can have a really negative effect on their emotional well-being and their mental health. It can also mean that they don't have the words or the ability or confidence to tell you what the problems are, so we can't address their needs in a way that's meaningful to them. So we think we're trying to do something useful, but we aren't. You're not able to say what your choices and preferences are. I always say that I'm going to be one of these ladies in hospital who's going to be really problematic because I don't like tea with sugar. If you give me a cup of tea with sugar, I would be really, really fed up with it. In fact, if I couldn't communicate it, I'd probably end up spitting it out as soon as I took a sip. I like coffee. I only drink coffee. Now, can you imagine how that might be perceived if I'm laying in a hospital bed and suddenly I start spitting my drinks out all over you? I might be seen as challenging, difficult, but what I'm actually saying to you is I don't like this. The implications of that are quite significant because obviously if I don't drink properly, I could become dehydrated, it could leave me vulnerable to infection, all those kind of things. And actually, that's just a very simple example of how important it is to understand what people are trying to communicate with you without making assumptions about what it is they're trying to say. People will probably say I'd be a bit difficult anyway, but in this instance, it would definitely be because of the tea with 2 sugars. Again, that frustration and agitation, if people talk over you or pretend that they've heard you when they haven't, sometimes it's really important to tell the person you don't understand what they've said. I've had similar family experiences whereby my mother actually was unable to communicate verbally, and I remember taking her to an appointment and she was trying desperately to make herself understood, and at the end of the appointment I asked her doctor whether the doctor had actually ever knew what she was saying. And they went, no. Yet all through that conversation, they'd nodded as if they understood what she was saying. So that's really disempowering for someone. It's, if you don't understand, it's really important to say, I perhaps don't understand what you're saying. How can we find a way to identify what it is you are trying to say? It could be that a family member understands that person better than you and they might be able to communicate. It may be that you just need to take a bit more time or go back to that person at a later point in the day. But actually, don't assume that you know what they're saying. If you don't, be honest and try and find a way of finding a solution to identify what might be going on. And we often hear this phrase about behaviour that's challenging. Well, actually, the behaviour is often a form of communication, and we will come back to that later in this session. So it's time to think about how we might improve. What resources have we got out there that might improve communication? The key one, and I think the one that's most fundamental of all, is getting to know the patient, the resident, the person you care for. That's the most important thing, because the more you know them, the more you'll be able to pick up on those non-verbal cues and clues. You'll be able to start to see when people might not be as confident or comfortable, that they might be becoming distressed, they might be becoming frustrated, or you might know what their preferences are. So thinking about finding out preferences, if someone's lost some of their communication skills, particularly if their dementia is more advanced, or they have hearing and other sensory deficit that's making it more challenging for them, what kind of things can you think of? Now, I'm quite a fan of visual cues and clues, so things like picture menus, for example. If you've got a resident or someone you're caring for at home who perhaps their appetite isn't so good, is it because you're giving them foods that they don't enjoy? And if you say to them, would you like fish and chips or a shepherd's pie or all those kind of things, they may not be able to retain all those questions that you've asked them, or they may not be able to put the words with a visual picture of what that food looks like. Imagine if you've never come, if you come from a different country and someone offers you a shepherd's pie, that might come up with all sorts of connotations of what you're offering them. But actually, if you show them a picture of some mincemeat with some potatoes, for example, it may feel that that's something that they can relate to more and they can point out what their likes and dislikes are. Things like the Alzheimer's Society This Is Me tool is really good. You can start to get families to engage and tell you a bit more about the preferences of that individual. So going back to my cup of tea and coffee example, if you know as a carer that I only drink coffee, you're not going to offer me tea with sugar because you know that I'm not going to drink it. You might know that I like sweet things as opposed to savoury things. So when my appetite is waning, you might be able to support me better in making my choices. Think about perhaps engaging with music as well. Music's a really good tool to kind of reassure someone, particularly if you think they're not particularly verbal. I can recall a situation many, many years ago where a lady I cared for some time didn't have any formed words. She would communicate with sounds and gestures. And one New Year's Eve, we had a healthcare assistant playing the piano, singing Auld Lang Syne, and I saw that lady sit upright and sing it word for word perfectly. And it still brings the hairs on the back of my neck sitting up, when I think about it now, because it was such a beautiful moment that we could never replicate, but it just demonstrated that that lady did have some communication there. It was about tapping into it in a different way. People might have key phrases and words that they use. I recall a friend of mine telling me when we were doing some training once that she kept saying that she had a gentleman who had lots of dressings on his leg because he had an oozing wound on his leg. And they kept saying to him, "How is your leg?" And he kept saying, "It's charging, it's charging." So she thought that meant discharging. And actually, when she inquired with him a bit more, what he was saying was there was pain charging down his legs. So again, it's about not making assumptions about those sorts of local colloquialisms, if you like, is understanding what people really mean by what they're saying, and what their local language is. Because obviously we use some very colloquial phrases and expressions that might mean completely different things in other parts of the country, let alone other parts of the world. Think as well about when that person might not be more able to communicate with you. It might not be first thing in the morning, it might be mid-morning when that person's more awake and alert and they've been up and about and, washed and dressed and had their breakfast. It might be in the afternoon. But again, it's thinking about when that person's more aware and awake. And actually, their ability to communicate might fluctuate if they're stressed or they're anxious or there's something else going on. So think about that, because just because they haven't understood you once doesn't mean that the next time they won't understand you again. As I said, do think about those cultural issues, and remember that not everyone has English as a first language. So it may mean that they revert back to their original mother tongue, and they may need support with translators. So do think about that. And it might be again that even if you can't have access to a translator 24 hours, 7 days a week, there could be key phrases that you could be supported to learn to enable that person to feel supported and safe. Sensory impairment. If someone's, that they've got difficulties with their sight or their hearing, make sure their glasses are available and they're clean. I tend to wear glasses a lot of the time, and there's nothing worse than trying to see through smeary glasses. But also hearing aids, making sure people's hearing aids are in, they're switched on, and that the batteries are changed. And I will again, I'm going to talk to you about a case study around that later, because I find that something that is very simple to rectify, but it can have a really detrimental effect. Said family members, really important. They often know that person very well. As I said, they might be able to pick up on those visual clues far better than we do if we don't know that person particularly well. And as I said again, behaviour is a form of communication. I get frustrated. You'll know when I'm frustrated by the way that I behave. If I'm angry, my posture will change, my behaviour will change. That's no different for someone with dementia. They still feel, they still have emotion, they still feel those, situations where they feel tense or content. You can tell when I'm happy by my posture as well. So, think about what's going on for that person at that time that might be creating them, making them feel agitated or upset, or it might actually be making them happy, because if you learn what's happening when someone's content and happy, you can replicate that rather than replicate the situations whereby they're really distressed. So thinking about it, making patterns is really important when someone's unable to communicate verbally. I always think this is such a big subject, communication and dementia, so I thought there's probably some ways of showcasing how that might manifest itself in some case studies. So the first lady I'm going to talk to you about is a lady called Doris. Doris was a lady who was in nursing care. She was in her 90s, quite frail, and was seen as very challenging by the staff. So much so that she was having 24-hour one-to-one care, which I think is quite an invasive thing to have. Someone sat beside you 24 hours a day. It's not pleasant. But the reason that this lady had this 24-hour one-to-one was that she was seen as aggressive. She was seen as really challenging, and the staff felt that they needed that extra support to meet her needs. I went in to meet Doris to review her, and I saw this very tiny, frail little lady curled up in a ball in her bed, who I couldn't think could be at all challenging, but the staff were reassuring me that this was definitely the case. The lady had been prescribed antipsychotic medication and things like lorazepam to keep her calm because of this situation. Now, Doris was really quite contorted. You could see that she was quite hunched over. Her hands were quite contorted, looked like she got lots of arthritis, and her muscles had gone into contractures. So obviously really quite uncomfortable. And the reason that she was seen as difficult is when they were doing personal care, she'd lash out. What was happening though for Doris was the fact that she was in pain. Doris was in pain when she was being moved. So that behaviour, that aggression or perceived aggression to the staff was about her trying to say, I'm uncomfortable. So what we did was we reviewed her pain medication. We got her some really good pain relief that met her needs more effectively than that she was already prescribed. We then managed to reduce her antipsychotic medication and the lorazepam and all the other things that she'd been taking. And actually, as a result, she was much calmer when staff were doing personal care, and she no longer needed a one-to-one. So this is what I say about the behaviour. Really think about it as an indication of someone communicating with you. Take a step back and think about what might be going on for that individual person. What might be the reason for this behaviour, and are there ways that we can think about it? Go back to the other training videos about delirium and behaviour as well. Tie those all in, because I think, this is about bringing together all these elements of care to be able to make care more comfortable for the person who's receiving it, but also to make your work much easier. Sensory impairment as well. I've seen people actually diagnosed with dementia who don't have dementia. They are perhaps hard of hearing or they're visually impaired and unable to engage in the assessment process. Again, it happens to be a care home setting, but I was asked to go and see a lady who was, she'd been admitted for a respite in a residential bed. She'd been living at home until recently, but had a few falls. So that was the reason why she'd gone in. There was no indication in her admission that she had cognitive impairment. During her stay, staff had said that in the afternoon she was getting really frustrated with them, she was shouting, she was being very, very difficult. Now, I've been doing this job for quite a while now, best part of 30 years. I know that's really difficult to believe, you know, looking so youthful as I do. But ultimately, yeah, I went in and I kind of got a sense that something wasn't quite right. She didn't strike me as someone who looked as if she was struggling with some task. She was sitting there knitting. She was you know, sort of smiled at me as I went in the room. The GP tried to do what we call the GP cog, which is an assessment tool to try and assess her cognition, and she really couldn't engage in it. But I noticed she had both hearing aids in. So I gestured to her, "Can you hear me? Are they switched on?" And she kind of went like this. So I took them out and they were switched on, but I said, let's just see if we can change the batteries. So we changed the batteries, popped both her hearing aids in. And when I started talking to her, her first expression was, "Don't shout, love." And I was speaking probably as I am now. I'm not the most quietly spoken, but ultimately, suddenly my tone felt like she was shouting because she could hear me more clearly. And you can imagine the GP looked a little bit embarrassed, as did the staff, because obviously for this lady, what was happening was she was getting frustrated because she couldn't hear when people were talking to her. Perhaps they'd come up behind her and it would frighten her. So this lady didn't have any cognitive impairment at all. What she did have was a hearing deficit that could be remedied by having her batteries changed. So think about perhaps those patients you know or residents you know who do already have hearing aids, or perhaps they've never had their hearing checked. There are hearing and sight tests that people with dementia can still engage with from the earlier stages right through to the moderate. So it could be that actually they have a sight problem that's never been addressed. They might have cataracts, for example, all those kind of things. And if you're aware, it helps you adapt your environment, adapt your communication in a way that might be able to aid them to have a voice. I think the key thing for me throughout when you're thinking about communication is just look at the individual, try and get an understanding of them as a person, understand what type of dementia they have, because it will impact on the issues they have with communication. So for example, someone with frontal temporal lobe dementia might be very articulate. They might be able to communicate really effectively. But what they might have is changes in personality and tone, which then impacts on their communication. Whereby someone with Alzheimer's disease might have more word finding difficulties. So really think about that person as an individual, their diagnosis, and the bigger issues that might be affecting them, particularly if they're an older person and might be more susceptible to hearing or sight loss, for example. I guess what I'm saying in a nutshell is put yourself in their shoes. Think about how you would feel in certain environments, what would make a difference. Sometimes just holding someone's hand, you know, that touch, being able to engage with someone on a non-verbal level can speak volumes. If you go back to my continence session, you'll remember that I was, if you haven't seen it already, I'd urge you to do so, where I was lost and I was in a different country and I couldn't find my words. And actually someone just came and they held my hand and went like that to reassure me that someone was going to help me. That to me spoke more than 1,000 words, and what you do every day will absolutely have an impact on someone. I use the example of the emotions and how we feel and how we behave and our ability to retain memory. So say, for example, you happen to be delivering some domiciliary care and you go into a person's house and that person, you're a bit terse with them, a bit sharp. You know, that could make them feel really uncomfortable and really upset. You leave and they still feel upset, but they can't remember why they feel upset because their memory doesn't allow them to think about that. All they know is they feel upset, they can't process it, and nothing changes until someone else comes in and changes that emotion for them. Whereas if you go in and you're engaged, you're warm, that person when you leave will feel relaxed and calm and feel like they've had a really positive interaction. And that's really what we're trying to do, is make sure that we are more mindful of how we behave and how that might be perceived by someone with dementia and how we would want someone to engage with us. This really is a whistle-stop tour. There's so much we could talk about, but this is just to kind of give you some overview and think about what else you might need to know as a carer, as someone looking after someone with dementia, and how you could adapt your way of working to meet those needs more effectively.
Thank you for watching. If you would like more information, please visit Norfolk and Suffolk caresupport.co.uk, where you'll find further training on our learning portal. The link for this website is in the description down below.